Good afternoon, distinguished professors, chairpersons. I'd like to thank Professor Dr. Hisham Fathy for the kind invitation to speak in this prestigious Congress. My talk today is about patient candidacy and age selection and competition. First of all, we need to know the mechanism of hearing. Sound waves are collected by the auricle, transmitted along the external auditory canal to the tympanic membrane. Movements of the tympanic membrane are transmitted through the middle ear ossicles to the middle ear, the cochlea. The movement of the fluid, the perilymph inside the cochlea, causes movement of the basilar membrane with the overlying hair cells responsible for hearing. This generates electrical impulses which are transmitted along the cochlear nerve to the auditory area of the brain, where it's interpreted as sound hearing, sound sensation, hearing sensation. What are the types of hearing loss? We have the conductive hearing loss. This type of hearing loss is caused when there is a problem either in the external auditory canal or in the middle ear, causing the conductive hearing loss. The problem is the conductive pathway for sound. Sensory hearing loss occurs when there is a problem either in the cochlea or in the cochlear nerve. When we have both elements present, we have the mixed hearing loss, and then we have the auditory spectrum disorder, auditory neuropathy, where there is a problem either in the inner ear or the nerve, so that the sound is organized in a way that the brain can't understand it. Causes of conductive deafness. Either congenital disorders, including genetic problems causing anomalies of the external or the middle ear. Congenital disorders predisposing to secreting otitis media, and this includes cystic fibrosis and otitis syndrome causing blockage of the sticking tube and cleft palate. Acquired disorders include inflammation such as acute and chronic otitis media, trauma, foreign body wax, and sclerosis. Sensorineural hearing loss causes include prenatal events that can cause sensory hearing loss, what we call congenital disorders or trying events. These include genetic inborn errors, either syndromic or non-syndromic. Of course, non-syndromic are much more common. Exposure to pathogens, including viruses such as rubella, cytomegalovirus, herpes simplex, and varicella virus. Exposure to radiation, alcohol, or toxic drug, or maternal diabetes. Perinatal events include hypoxia, hyperbilirubinemia, and preterm delivery. Postnatal events, acquired disorders, this is they are either idiopathic, infections such as meningitis, measles, mumps, or as a complication of acute and chronic otitis media, autoimmune diseases, Meniere's disease, cochlear otosclerosis, ototoxic drugs, trauma, and neoplastic lesions such as cerebellocontaminant lesions. What is the mechanism of sensory hearing loss? In case of congenital disorders, genetic inborn errors cause incomplete or aberrant development of the inner ear. Exposure to pathogens cause incomplete or aberrant development of the inner ear. Viruses cause viral labyrinthitis, which cause a condition known as labyrinthine ossification, which is characterized by first fibrous tissue formation followed by metaplastic bone formation inside the union of the cochlea, with subsequent atrophy of the hair cells and spiral ganglion cells. Other pathogens include radiation, alcohol, and toxic drugs. Perinatal disorders, we have hypoxia, acidosis, hyperbilirubinemia by connectors, and preterm delivery. There's immature metabolic functions. Acquired disorders, in case of infections, like meningitis or complication of acute and chronic otitis media, they cause either serous or suppurative labyrinthitis with subsequent or ossification and atrophy of the hair cells. Measles and mumps virus cause viral labyrinthitis with subsequent ossification. Trauma, autoimmune or cochlear sclerosis, but also cause ossification and atrophy of the hair cells. Dr. Hani has stated in details most of the symptoms that can cause sensory hearing loss. So I don't have a lot to say, but anyway, we have the Usher syndrome. It's the most common cause of blindness in humans. It's autosomal recessive. Type 1 is the most severe, consisting 30–40%. It causes severe to profound congenital sensory hearing loss, motor developmental delay, and progressive retinopathy. Early implantation in these patients is crucial for developing effective oral and auditory skills prior to visual loss. The Waardenburg syndrome, this is autosomal syndrome, characterized by hyperplasia of the eyebrow, heterochromia iridis, wide forelock, variable degree sensory hearing loss, and increased incidence of auditory neuropathy. Keratitis ichthyosis deafness syndrome. This is a rare congenital disorder of the ectoderm caused by heterogeneous mutation in the connexin 26 gene. It's an autosomal dominant. Consists of congenital ichthyosis, vascular keratitis, sensory hearing loss, alopecia, and possibility of squamous cell carcinoma occurrence. Cochlear implantation gives good results. However, the fear comes from wound complications with the failure of to heal with the possibility of extrusion of the implant. The American Academy of Pediatrics recommends hearing screening for all newborns. The goal is to have the newborn screened by the age of 1 month before hospital discharge, so that if there is hearing loss, it can be identified by the age of 3 months with proper intervention by the age of 6 months. Why do we need hearing screening for the newborns? Without hearing screening for the newborn, it might be hard to know when there are hearing changes in the first month or years of the baby's life. Sometimes babies respond to noise by startling or turning their heads, but this doesn't necessarily mean they can hear all the sounds around them. They might hear some sounds, but not enough. Infants who are deaf or have a hearing problem need the right support, care, and early intervention to promote healthy development. The late diagnosis and intervention will affect the baby's communication and language skills. On the long term, missed hearing loss can impact child academic achievement and socio-emotional development. In the United States, over 98% of the newborns have hearing screening. Currently in Egypt, hearing screening is now compulsory for all newborns starting from September 2019. There are 2 tests for hearing assessment in newborns. The automated auditory brainstem response. This test measures how the hearing nerve and the brain respond to sounds. Clicks or tones are played through the earphones into the baby's ears, and 3 electrodes placed on the baby's head measure the hearing nerve and the brain's response. Second test is the autoacoustic emissions. This screen or test measures sound waves produced in the inner ear. A tiny probe is placed inside the baby's canal. It measures the response when clicks or tones are played into the baby's ears. Both tests are quick, painless, can be done while the baby is sleeping or lying still. We use either one or both means as a test to screen newborns. The current Egyptian protocol for normal newborns include that we do autoacoustic emissions in the first week, and if failed, we repeat it within 1 month, and if failed, we refer for diagnostic AR. In case of newborns who have high risk, one of the highest factors for the development of sensory hearing loss, the previously mentioned causes of sensory hearing loss, both tests are done for screening before hospital discharge, and we repeat them if failed within 1 week, and if failed, we refer for full diagnostic evaluation. Follow-up. Even if the baby passes the newborn hearing screening, you should still watch for possible signs of hearing loss as the child grows. If you find one of the following points, you should talk with the pediatrician and consult. If the baby doesn't start to let loud noises by the age of 1 month, return towards sounds by 3 to 4 months, doesn't notice you until he sees you, if he's slow to begin talking, hard to understand, or doesn't say single words such as dada or mama by the age of 12 to 15 months of age, doesn't always respond when called, hears some sounds but not others, has trouble holding the head steady or sitting or walking unsupported, because sometimes when we have sensory hearing loss, it is, there is vestibular dysfunction along with it. The American Academy of Pediatrics recommends that even if there is no signs of hearing changes, she should be screened again at the ages of 4, 5, 6, 8, and 10 months. Additional screening might be needed between the ages of 11 to 15, 15 to 17, and 18 to 21, or at any time if there is a concern. More frequent screening, follow-up screening, may be needed when there is a high-risk factor. Hearing loss sometimes is gradual and hard to notice at first. The routine screening can catch hearing changes early when providing support resources can have the most impact on child development. Remember that timing is everything. The sooner hearing changes are identified, the more likely the intervention can help reach the full potential. If your baby's audiologist confirms hearing changes, then early intervention with a team of providers should start as soon as possible. Studies have shown that if the baby will get the best chance for spoken language development if hearing changes are early discovered, and the proper intervention begins by the age of 6 months. Every baby who is deaf or diagnosed as having hearing problems should be seen by pediatric otolaryngologists specialized in the mechanism of hearing, pediatric ophthalmologists. Some children may have visual impairment problems, geneticists to determine the hereditary cause of hearing loss or changes. What are the indications for cochlear implantation? Patients with bilateral, severe to profound sensory hearing loss, and there is no benefit from hearing aid, and the speech recognition test is below 50%. There should be no retrocochlear lesion contraindicating implantation. We're going to discuss this later, and there should be patent cochlear partition allowing for implantation of the electrode inside the cochlear lumen. Contraindications include presence of retrocochlear lesions such as eighth nerve aplasia, organic brain dysfunction. There's absent cochlear development, either cochlear aplasia or cochlear labyrinthine aplasia, means deformity, mental retardation, psychosis, prelingual deaf adults. This is going to be discussed later. And if there is a tympanic membrane perforation, signs of infection such as acute suppurative otitis media. What is a cochlear implant? Cochlear implant consists of two parts. First, the internal part, which is implanted during the surgery. It consists of the receiver stimulator, which is implanted in a well drilled in the skull beneath the tight periosteal pocket. Out of it comes the electrode array. This is the electrode array, which is implanted inside the cochlear lumen. And you have the external part, which is worn 6 weeks after surgery, consists of the microphone, processor, and the transmitter. This diagram shows the internal and external part. The external part consists of the microphone, processor, and the transmitter with its external magnet attached to the magnet of the internal part. Some pics for the surgery, the surgeon performing the cochlear implant surgery. The implant device in its bed during surgery. Another picture. This is the implant in its well, in the skull, and the electrode going into the mastoid cavity and into the cochlear lumen, and the baby post-operative. How does a cochlear implant work? The sound is received by the microphone. The microphone sends the sound to the processor, which in turn digitizes these sound waves into Bode signals and send them to the transmitter. The transmitter sends these signals across the skin to the receiver stimulator of the internal part. These signals travel along the electrode array to stimulate the remaining nerve fibers in the cochlea. Electrical impulses are then sent across the cochlear nerve to the auditory area in the brain to be interpreted as sounds. The age of the implantation, the speech articulation is accomplished by the age of 2 years. The neuroplasticity is the ability of the CNS to be programmed to learn a certain task. The plasticity for listening is lost by the age of 6 years, and therefore cochlear implantation should be done before the age of 6 years, which is the time for loss of neuroplasticity for listening. In case of congenital sensory hearing loss and children who develop sensory hearing loss before the age of 2 years, what we call prelingual deaf children, it has been shown that in terms of speech development and language, the best results come when the children are implanted under the age of 2 years, similar to normal hearing children. The age for implantation changed along time by the FDA. In the year 1990, it was around starting from 2 years. In the year 1998, starting from 1.5 years, and in the year 2000, starting from 1 year. By the year 2010, implantation has been reported in children younger than 1 year. It has been shown that children implanted below the age of 1 year, and compared to children implanted between the age of 1 to 2 years, they have superior speech understanding, and they actually show language skill growth rate similar to normal peers. In case of postlingual deaf children, when there is hearing loss after the age of 2 years, the younger the patient is exposed to hearing loss, the more there is loss of speech, as the vocabulary dictionary is not yet well developed. Implantation should be done as soon as possible to decrease the time of hearing deprivation, and hence speech deterioration, and before loss of neuroplasticity for hearing. For adults, in Prelingual and postlingual if others, these are excellent candidates. However, they should be implanted as soon as possible. As the longer the time of field degradation, the more resistance ganglia and hair cell degeneration, and the poorer the outcome is. The prelingual deaf others, these are very poor candidates for implantation unless they have developed speech using alternative methods for communication. Thank you for your attention.
Thank you very much, Dr. Hisham Fathy, أستاذ ورئيس قسم جامعة القوقعة في القصر العيني. Very interesting talk. ونتأمل إن شاء الله نحكي في الجيناتكس.